Some orthopedic and sports imaging specific to the knee. We're going to be talking about three pathologies today: patellar tendinopathy, patellar instability, and OC lesions of the knee. The first topic I want to cover is patellar tendinopathy. The predominant pathological feature of patellar tendinopathy is tendinosis, typically in the deep posterior portion of the patellar tendon adjacent to the inferior pole of the patella. Remember that tendinosis is characterized by a progressive tissue degeneration with a failed reparative response and the complete absence of inflammatory cells. Here's an X-ray of a normal knee. The normal patellar tendon thickness is about 0.5 centimeters, or roughly about 70% the thickness of the accompanying quadriceps tendon. Here we can see an ossicle present just inferior to the patellar pole. This tendon calcification is typically due to repetitive traction of the patellar tendon origin. This is a lateral X-ray of a 25-year-old who's been experiencing anterior knee pain for about 3 months. Notice a tendon calcification along the patellar tendon attachment near the tibial tuberosity. MR is one of the more common imaging modalities. A common finding on MRI is increased signal in the posterior region of the proximal patellar tendon and the inferior pole of the patella, as well as tendon thickening. An advantage of MRI is that it provides a broad spectrum investigation of the knee, allowing for delineation between intra-articular pathology or any other pathology that may be present. Contrarily, the disadvantages of MRI are ones that we've covered before in this course, such as cost and time required to complete the entire scan. This is a sagittal T2 image. What's nice about a T2 MRI is that any edema or bony pathology will show up as a white signal. Encircled is a partial thickness tear of the patellar tendon just off the inferior pole of the patella. Here's a sagittal T1 image. In this case, there is diffuse patellar tendinosis, sparing the portion that passes anterior to the patella to fuse with the quadriceps tendon. Here's another T2 sagittal MRI. Notice how there are degenerative changes present within the patellar tendon, which appear as white streaks on a T2 image. Musculoskeletal ultrasound is a great up-and-coming tool for orthopedic and sports medicine clinicians. These images are quick to perform in clinic and can be performed under dynamic conditions. Ultrasound is heavily dependent on the skill of the clinician, and they don't allow a full visual exam of the knee to rule out any other potential pathologies, like a patellar fracture. This is an ultrasound of a normal patellar tendon. Notice the smooth parallel fibers within the tendon. Here we see an abnormal ultrasound image with the patella still oriented on the left-hand side. Notice the hypoechoic area characteristic of the degenerative process associated with tendinopathy. This is a 28-year-old male with a 9-month history of anterior knee pain. The patella is oriented to the right-hand side. Notice how the thickened and hypoechoic area extends along the inferior pole of the patella. This is from the same case as the last slide. Notice the hypoechoic region along the deep fibers of the patellar tendon as they attach to the patella. Also notice the cortical irregularity of the inferior pole of the patella. As much as we would love to hang our hat on imaging for patellar tendinopathy, several studies have called into question the accuracy of imaging and clinical correlation. There have been both false positive and false negatives. There also does not appear to be a correlation between severity of a patient's clinical symptoms and what the tendon looks like on imaging. Unfortunately, there have also been mixed results for using images to correlate with how a patient is progressing. After surgery, there are still positive imaging findings of patellar tendinopathy. You can probably speculate that after physical therapy interventions, such as eccentric exercises, imaging findings may still remain the same. These are the reported positive and negative predictive values for both MRI and ultrasound images. The main takeaway is that MRI and ultrasound are sensitive to abnormal tendon morphology. Given the higher positive predictive value of these imaging modalities, it would be useful to utilize imaging to increase the overall likelihood of patellar tendinopathy and correlate any clinical findings. If imaging reveals characteristic features of patellar tendinopathy that seem to fit the clinical presentation, then treat as such. If imaging for the patellar tendon is normal, then you should investigate other potential causes for the patient's knee pain. Let's change gears now to another pathology about the patella, patellar instability. On this AP view of the knee, you can clearly see a laterally dislocated patella. The sunrise view is a common view to investigate various patellar pathologies that we'll be talking more about in this section. The sunrise view is a great way to investigate patellar alignment and trochlear depth, two important concepts when evaluating patients with patellar instability. These are the three primary anatomic risk factors for patellar instability. We're going to touch on each of these individually. Trochlear dysplasia has been identified as one of the main factors contributing to chronic patellofemoral instability. In individuals with trochlear dysplasia, the trochlear joint surface is flattened proximally and the concavity is less pronounced distally. This combination results in considerable loss of lateral patellar tracking and in lateral dislocation of the patella at the initiation of flexion. Because of its high frequency of occurrence bilaterally, trochlear dysplasia is believed to be a developmental anomaly. There are 4 types of trochlear dysplasia, but for the purpose of today's lecture, we're just going to simply focus on generalized trochlear dysplasia as a whole. The crossing sign is a line represented by the deepest part of the trochlear groove crossing the anterior aspect of the femoral condyles assessed from lateral radiographs. Normally, the femoral trochlea will be deep enough that it will not protrude beyond the femoral condyles. In a patient with trochlear dysplasia, the flattened trochlea will oftentimes lie in the same plane as the anterior border of one of the femoral condyles, typically in the lateral femoral condyle. The crossing sign is sensitive but not specific in investigating trochlear dysplasia. In the X-ray on the right, we can see a normal lateral knee radiograph of a 19-year-old man that shows that the femoral trochlear groove, indicated by the black arrowheads, does not cross the femoral condyles. In the X-ray on the right of a 15-year-old male, we can see a crossing sign, which occurs when the deepest part of the femoral trochlear groove, indicated by the white arrows, crosses the anterior aspect of the femoral condyles, which is indicated by the solid arrow. One way that we can measure the amount of trochlear dysplasia is to look to see how much of a bony buttress the patella has on the lateral aspect of the knee. If there is a higher bony block there, as would be indicated by a higher inclination angle, then the chance for a lateral patellar instability decreases. So to measure the angle, a line is first drawn along the lateral trochlear facet. A second line is then drawn horizontally along the posterior aspect of the femoral condyles. The angle between these two lines is then measured to indicate the amount of lateral trochlear inclination. Remember from math that the horizontal line drawn along the posterior aspects of the femoral condyles may be drawn closer to the lateral trochlear facet as long as it's perpendicular to the original line, as it is in all 3 of these MRIs. This makes it a little easier to visualize and measure the inclination angle. As we look at these images from left to right, we can see how a more shallow or dysplastic trochlear groove results in a smaller lateral trochlear inclination angle and thus less of a lateral buttress for the patella and a higher risk for lateral patellar instability. The normal lateral trochlear inclination angle is approximately 11 degrees, with trochlear dysplasia identified as angles less than 11 degrees. The sensitivity is quite high for this measurement. Another way we can measure the amount of trochlear dysplasia is to measure how deep the trochlea is. First, a reference line is drawn horizontally along the posterior aspect of the femoral condyles, indicated by the green line labeled D. Next, a line is drawn from the highest point of the lateral femoral condyle, labeled as line A. Another vertical line is drawn from the highest point of the medial femoral condyle, labeled line C. A third line is then drawn from the deepest part of the trochlea, labeled line B. We have to use a little math to measure the trochlear depth. It's simply the average height of the femoral condyles minus the trochlear offset. The trochlear depth of this image on the left was measured as 12 millimeters, whereas the image on the right was measured at 1.5 millimeters. We can again see how a shallow trochlea will decrease the lateral buttress for the patella and subsequently increase the likelihood of developing lateral patellar instability. These are the reported sensitivity and specificity values for measuring trochlear depth. Again, these radiographic measurements are more sensitive than specific. Patella alta is considered another main factor in patellofemoral misalignment because with patella alta, the degree of flexion needs to be higher for the patella to engage within the trochlea compared with a normal knee. This problem leads to a reduced patellar contact area and decreased bone stability in shallow degrees of flexion. Patellar height can be measured on an X-ray or preferably an MRI. However, I simply want to expose you to what patella alta looks like on an MRI and the fact that it can be specifically measured. The position of the tibial tubercle is crucial for the inferolateral force vector of the patella. In a normal joint, the tibial tuberosity lies vertically under the femoral sulcus, directing the force vector inferiorly during knee bending. However, if there is excessive lateralization of the tibial tuberosity, the patella is pulled laterally during flexion. Therefore, excessive lateral displacement is considered a risk factor for instability. The tibial tubercle trochlear groove, or TT-TG distance, is a method to assess extensor mechanism valgus alignment and patellar instability. It is measured as the distance between the lines drawn through the deepest part of the trochlear groove and the anterior prominence of the tibial tubercle attachment of the patellar tendon. Here we see how two axial MR images are used to measure the TT-TG distance. In image A, a horizontal reference line is drawn along the posterior femoral condyles. A vertical line is then drawn through the center of the deepest part of the trochlear groove. In image B, the two yellow reference lines from image A are superimposed. A second vertical line, drawn as a white dotted line, is extended through the center of the patellar tendon attachment on the tibial tubercle. The distance between these two vertical lines is then measured, representing the TT-TG distance. The normal TT-TG distance is between 10 to 15 millimeters. It's not too hard to conceptualize how a larger distance will result in a more valgus alignment and thus a higher likelihood for lateral patellar instability. Here we can see two CT images, 7A and 7B, superimposed on each other using the same method as the MRI from the last slide to create image 7C. Line A represents the posterior intercondylar reference line, line B represents the trochlear groove line, and line C represents the tibial tubercle line. With a TT-TG measurement of 25 millimeters, we can deduce that this patient is at risk for patellar instability. Now that we've talked about some of the osseous abnormalities seen and measured on imaging, let's change gears now to some of the soft tissue structures that may become affected by a patellar instability episode. There are two major medial stabilizers of the patella, the medial patellofemoral ligament, MPFL, and the medial patellar retinaculum. With a lateral patellar dislocation, we oftentimes see a disruption of the MPFL, which may also cause a direct impaction injury to either the medial side of the patella and/or the lateral femoral condyle, which we'll talk about later. Here we see another drawing showing a lateral patellar instability episode and its effect on both the MPFL and the medial retinaculum. Disruption of these stabilizers is diagnosed on MR images in 70 to 100% of the patients examined after lateral patellar dislocation. MR imaging has a sensitivity of more than 80% when correlated with open surgical exploration. The MPFL and the medial patellar retinaculum may be difficult to differentiate, especially at their patellar insertion, where they blend with each other. This is an MRI of a normal knee with both of these structures intact. MPFL tears can be identified by where specifically the tear occurs. Between 50 and 90% of the injuries to the MPFL involve the patellar insertion. 25% of the time, an avulsion tear of the MPFL at the adductor tubercle occurs. Accurate characterization of the type of ligamentous tear is important because the findings from the most recent studies indicate that femoral avulsion is a predictor of chronic instability, which is why the site of the tear may directly affect surgical planning. This is a T2 axial MRI of a 27-year-old male patient with an uninjured MPFL and medial retinaculum. The white arrows show a continuous depiction of the ligamentous fibers as they traverse to attach at the adductor tubercle, represented by the white arrowhead. This is a 24-year-old female patient who suffered a patellar instability episode. The white arrows indicate the area of MPFL disruption. Notice how the ligament fibers appear irregular and are surrounded by edema along the femoral third. This is suggestive of a partial tear of the MPFL. In this image of a 39-year-old female, we can see a detachment of the femoral MPFL origin, indicated by the white arrow. We can also see a partial tear of the patellar insertion, indicated by the white arrowhead. Here we see a complete disruption of the medial stabilizers, indicated by the white arrow. Wavy or retracted fibers surrounded by effusion are conspicuous for complete disruption. The arrowhead shows fragments of the patellar insertion of the MPFL, while the black arrow points to fragments of the femoral origin. Let's transition now to the osseous structures about the patellofemoral joint that may become affected by a patellar instability injury, more specifically bone edema of the patella and the lateral femoral condyle. Osteochondral lesions can also occur, but we'll touch on those later on. Typically, T2 weighted images are used for detection of bone edema, as these injuries will have a high signal intensity compared to the darker signal of the bone. Here we can see bone marrow edema of the lateral femoral condyle on a T2 axial image of a 23-year-old female patient. In this coronal T2 MRI of an 18-year-old male patient, we can see extensive bone edema of the lateral femoral condyle. This is a head-on view of the patella in a T2 coronal MRI of a 24-year-old male patient with a bone bruise of the inferomedial aspect of the patella. Let's transition now to injuries that are becoming increasingly common and more often researched in several joints of the body, osteochondral or OC lesions. These are focal areas of articular injury with damage to the cartilage and the adjacent subchondral bone. They occur most frequently due to repeated microtrauma or an acute injury mechanism, such as twisting, pivoting, or contact collision in sports. They are oftentimes referred to as OCD injuries, abbreviation for either osteochondritis dissecans or osteochondral defects. However, the new trend is to refer to them as OC lesions. Most, about 80 to 85% of OC lesions of the knee occur about the medial femoral condyle. Not pictured on this diagram are patellar OC lesions, which only account for about 5% of cases. X-rays are typically done as part of a routine orthopedic examination, but specific findings of OC lesions may be difficult to detect, especially in the early stages. Early findings include subtle flattening or indistinct radiolucency about the cortical surface. As the process progresses, more pronounced contour abnormalities, fragmentation, and density changes, both lucency and sclerosis, become evident. This is an X-ray of an OC lesion along the medial femoral condyle. It can be important to stage the OC lesion as it can help predict the extent of the injury and, in turn, predict the stability of the lesion. Stage 1 injuries typically only involve the articular cartilage without clear margins of injury. In Stage 2, we see an extension of the injury into the subchondral bone to form clearer margins. In Stage 3, fluid completely surrounds the entire fragment, but the fragment remains in place. In Stage 4, the fragment actually becomes displaced. Even though staging is typically done utilizing an MRI, we can at least see in these two X-rays the difference in types or stages of the OC lesion. In the image on the left, it seems like the patient has a Stage 2 or 3 lesion of the medial femoral condyle. In the image on the right, we can clearly see a Stage 4 lesion as the osteochondral fragment has become displaced from the medial femoral condyle. MRI is the imaging modality of choice for OC lesions, with high sensitivity at 92% as well as high specificity at 90% in the detection of separation of the osteochondral fragment. This is essential in staging, which we talked about in the last slide, and thus helping to determine clinical management. Note the difference in appearance of the OC lesion of the medial femoral condyle on a T1 versus a T2 MRI. Here we can see an OC lesion of the lateral femoral condyle. Notice how there is an outline of edema around the lesion, but it appears to still be contained, so it's likely a stage 3. This is a medial femoral condyle OC lesion in a 19-year-old male that was deemed to be unstable. Notice how the T2 weighted image allows us to visualize the edema around the fragment that has begun to migrate away from the medial femoral condyle, resulting in the determination that this is an unstable lesion. Here's a T1 MR image of an OC lesion of the lateral femoral condyle. Notice how the lesion is encapsulated just as we saw in the T2 images. However, rather than a bright, high signal surrounding the lesion like in a T2 image, we see a darker outline of the lesion in a T1 MRI. We've looked at a lot of coronal slices, so let's take a look at a sagittal slice. Here we can clearly see how posterior this OC lesion extends into the femoral condyle of this 18-year-old male patient. The dark outline of the lesion is again seen in a T1 weighted image. As we've mentioned throughout this imaging course, CT scans are best utilized for bony pathology. The articular cartilage and other soft tissues of the joint is not as easily visible as in an MRI. This makes staging the OC lesions quite a bit more difficult, especially the more subtle stage 1-2 lesions. All in all, CT scans have similar imaging findings to conventional X-rays, so they may be reserved for those patients who have contraindications for MR imaging. You're going to learn a lot more about different surgeries for cartilage injuries of the knee, which may include a compression screw, microfracture, or OATS. So these are my references, and thanks guys for listening.